Several years. Several of my colleagues to the right. The judges.
Is that the political right or the?
A mixed bag.
No one ever declared, so I'm a little bit unsure. But
Excuse me for interrupting.
no, I think everyone tried their best to be nonpartisan in this for sure. But the judges made a great recommendation, and that is before we actually begin our presentation, perhaps we go around not only the table and the panel here, but also all of our guests in the audience for the record to be able to identify yourself and who you're with. I'll be happy to start. I'm Glenn Robinson. I had the privilege of retiring from Baylor Scott & White in 2020 after 13 years and continue to work in the healthcare field, doing healthcare consulting and leadership coaching, and proud to continue to live here in Waco, the city of Waco, as well as our great county. It's also been an honor to serve on this panel over the past few years.
Hello, my name is Ryan Adams, and I'm the CEO for Heart of Texas Behavioral Health Network, the local mental health authority here in McLennan County that also serves 5 other rural counties here in Central Texas.
And I'm Chris Lancaster. I'm the president for Baylor Scott & White Hillcrest here.
And I'm Philip Patterson. I'm the market president for Ascension over the Providence Health System.
Okay, I am County Judge Scott Felton.
D.L. Wilson, Commissioner Precinct 2, McLennan County.
Will Jones, County Commissioner, Precinct 3.
Jim Smith, County Commissioner, Precinct 1.
Jim Holmes, Mayor Waco.
Darius Ewing, Waco City Council.
Josh Woodward, Waco City Council.
Okay, Dustin, introduce yourself.
Dustin Chapman, I'm the County Administrator.
Jessica Hattis, CEO of Friends for Waco. Ashley Allison, Executive Director of Waco Foundation.
James Stone, Waco Foundation.
She's City Attorney. Michelle, City Secretary, City of Waco. And we have Councilmember Andrea Bearfield virtually. She's in the waiting room.
Get her in, don't we?
Candy Spice, Assistant City Secretary, City of Waco. Lisa Lockwood, Assistant City Manager, City of Waco.
Monica Sattlemyer, Chief Communication Officer, City of Waco. Deidre Emerson, Deputy City Manager, City of Waco.
Bradley Ford, City Manager.
Christy Brault, McLennan County, Precinct 1 and 4, Executive Assistant.
Brian Holt, City of Waco, Assistant City Manager.
Paul Kane, Assistant City Manager, City of Waco.
That's it. That's it. Move this. Hopefully you can hear me just a little bit better. As I get started, I just want to say a special thanks. I mentioned Ashley Allison earlier and co-facilitator of this group. Also, I'd like to thank Jessica Addis and Dr. Jackson Griggs. Dr. Griggs, by the way, of Waco Family Medicine, could not be here today. Very much wanted to, but the calendars worked out well for our city council and our county commission, and so we thought we better take advantage of being able to be present. I'd also like to say a big thanks to James Stone and his work from the Waco Foundation. Also, all of those that served on the PACES committee, they're listed in pages 13 and 14 of the report that has been submitted to the county commissioners, and greatly appreciate representation from the county commission, Dustin Chapman, also Judge Felton, Bradley Ford, our city manager who is here, Dr. Griggs, Mayor Jim Holmes, Chris Lancaster and Philip, as well as Ryan Adams, who are to my right, and James Stone, as I mentioned, and also Patricia Young-Brown. She's the Chief Partnership Officer of the Design Run Group. We turn to her because of her vast experience in looking at how many communities across our great state of Texas come together to be able to address the healthcare needs. Let me share with you just some opening remarks, and again, I greatly appreciate the City Council, Mayor Holmes, Judge Felton, and the County Commissioners joining us. Last summer, your two bodies each generously approved funding for a study of our healthcare system in Waco and McLennan County, and today we're here to present to you a final report from that effort. The Partnership for Accessible Care and Economic Sustainability, or as we call PACES, was born out of a shared recognition. And it is this: the strength of our local healthcare system is inseparable from the strength of our workforce and our local economy. For nearly 2 years now, a coalition of hospital executives, primary care physicians, behavioral health leaders, government officials, nonprofit executives, and other community representatives comprising the PACES task force have worked to understand the state of health care in Waco and McLennan County. We've seen the pressures that are on our healthcare system building for years through rising costs, shifting federal and state policies, and a high uninsured rate that is nearly double the national average. But the phase 1 process that we just completed has put data behind what many of us have long suspected, and it is this. If we do not as a community act strategically, the healthcare system that we currently enjoy and that supports our residents, our businesses, and our economic growth of our community will steadily erode. Our purpose today is not just to share what we found, but also to connect those findings to what they mean for you as decision makers and as leaders in our community. As you receive our presentation today, we would ask that you keep one central idea in mind, and that is this. Healthcare is not just a cost center, but it's an essential part of our economic infrastructure as a community. In Waco, a little more than 20% of our working age adults, more than 20%, more than 1 in 5, have no health care insurance. That is not just a statistic about access to care. Unfortunately, it's a statistic about workforce productivity, about business competitiveness, and ultimately about a cost to all of us as taxpayers. Without early and regular access to primary care and preventive services, we see many more avoidable hospitalizations, higher uncompensated care, and people leaving the workforce earlier due to preventable health conditions. And while the PACES analysis shows that these trends are unsustainable, it also demonstrates that with strategic planning and with action, they may also be preventable. And that's the good news today. By focusing on upstream solutions like expanding primary care, integration of behavioral health, and management of chronic disease, we can reduce the strain on our hospitals, free up capacity for growth in our community, and improve the overall economic and physical health of our entire community. Today's presentation is structured to give you both the big picture and also some ground level reality. You'll hear from hospital executives about the operational strain that they face each day, and from our behavioral health system about the pressures that they are under, and from all of us about the return on investment that we can achieve when we address problems before they become a crisis. The issues facing our healthcare system are not about one organization or one particular sector seeking a solution to this problem. It is truly about a coordinated planning, a sustainable financing, and measurable outcomes that benefit the entire community. At the end of the presentation, we'll share the PACES Task Force Phase 1 recommendations with you. And I encourage you to listen to this presentation through 2 lenses today. First, the lens as a civic leader, thinking about what will keep our residents healthier and our systems more resilient. But second, as stewards of the local economy, thinking about how to protect our region's capacity to growth, to attract talent and new businesses to our community, and to compete effectively across the great state of Texas. The work ahead is complex, but the opportunity is clear. Let's start by hearing what healthcare leaders are seeing on the front lines. I now invite Chris Lancaster, Philip Patterson, and Ryan Adams to also be able to make presentations today, and I'll turn it over to Chris.
Yeah, thank you, Glenn. I can tell you from the perspective of a health system executive, these challenges we're talking today aren't just theoretical. They're visible in our hallways, in our waiting rooms, and even in our finances. When 1 in 5 working age adults in our community does not have health insurance, the emergency department becomes the front door for too many people. We often see patients whose conditions, whether it's unmanaged diabetes, high blood pressure, or an untreated infection, could have been addressed in a primary care clinic setting at the fraction of the cost. However, without coverage or consistent access to primary care, they come to hospital emergency rooms late and often much sicker than they should be. That delay in care is not just more expensive, it's harder on the patients. This could mean longer recoveries, more complications, and a higher chance of having to be readmitted back into one of our facilities. For hospitals, it means more uncompensated care, higher staffing needs, and less capacity for planned specialized services. Beds that could have been available for stroke victims or complex surgeries are instead occupied by people in crisis from preventable conditions. This isn't about blaming individuals, it's about recognizing that the system we have today all but guarantees these outcomes. This dynamic is costly for everyone, raises the cost of insurance for employers, increases the tax burden on residents who fund public health and safety net programs, and it limits hospitals' abilities to reinvest into innovation, technology, and the kinds of specialty care that keeps people here instead of having to travel to other cities for treatment. When we strengthen primary care and ensure timely access to treatment, we reduce preventable emergencies, open up capacity for the services only hospitals can provide, and deliver better results for patients at a lower cost. So when you hear later about investments in primary care and integrated behavioral health, understand that from a hospital standpoint, those aren't just nice to have, and they're essential elements for protecting both the health of our community and the long-term viability of our hospitals.
Thank you, Glenn. Thank you, everybody who's here. I want to just take the opportunity to talk not as a hospital executive, but somebody who is now what I feel is a community member. I've been here 8 years, and Waco is my community. I'm deeply invested in the health and the future of this city and our county. What you've heard so far from my colleagues about the pressures on emergency departments, behavioral health systems is absolutely real. At Ascension Providence, we see it every day. But I want to widen the lens and talk about what this means at a system level and why it matters for our region's future. I have 4 brief points. The first is that fragmented healthcare systems lead to reactive spending. Our current healthcare delivery and model is fragmented. There's no single entity aligning investments with the highest return solutions. Hospitals, clinics, and not-for-profits are often left to fill the gaps with short-term fixes. That keeps us reactive, not strategic, and it's costing all of us. 2, preventable hospitalizations limit growth. When 20% of our working-age population is uninsured, and when behavioral health crises go unmanaged, we spend a disproportionate amount of our resources reacting to emergencies. That ties up beds, staffing, and funding. Resources that could otherwise be used to expand specialty care, invest in innovation, and recruit top medical talent. This isn't just a healthcare issue. As they've said before, it's an economic one. When our hospitals are at or near capacity managing preventable conditions, our ability to attract new employers and grow our economy is compromised. 3, we know it works. Expanding access to primary care, integrating behavioral health, managing chronic disease upstream, these aren't theoretical solutions. They are proven strategies that free up hospital capacity, improve outcomes, and lower the cost of health care. At Providence, our physicians and staff are doing everything they can with the resources we have, but without a coordinated, sustainable plan for upstream care, we will always be playing catch-up. So 4, mine is just a moment of opportunity that we all have. With the right investments and shared commitment to coordination, we can protect our hospital capacity, improve patient outcomes, and position Waco as a destination for healthcare excellence. Reducing strain on our hospitals isn't about making today easier. It's about creating conditions for tomorrow's growth. Thank you for your leadership and being part of this important conversation today. Thank you.
Thank you very much for having the opportunity to speak with you today. Behavioral health is one of the most critical pressure points in our local healthcare system, and it's one we can't afford for it to be secondary. When mental health and substance use needs go unmet, they don't just disappear, they worsen. They show up in our emergency rooms, in our jails, and in our workplaces, absenteeism, lost productivity, and preventable crises. The truth is, our community's behavioral health needs have been growing steadily for years and the system designed to meet them has not kept pace. McLennan County has limited psychiatric bed capacity and a shortage of behavioral health providers. This results in long wait times for people in crisis, and in some cases, no timely access to treatment at all. Much of the care we do provide is being delivered in primary care settings that were never resourced for this level of demand. In 2023, the Heart of Texas Behavioral Health Network delivered more than 5,700 behavioral health visits to over 500 residents, many with chronic conditions, through integrated care and counseling models that worked. And this was in partnership with our friends at Waco Family Medicine. Overall, Behavioral Health Network delivered over 60,000 outpatient behavioral health services to almost 6,000 residents. But the funding that supports this is pieced together with state allocations that can shift from one legislative session to the next, and often do. This instability makes it difficult to plan, expand, or retain workforce as we need. And underfunded behavioral health doesn't just strain our providers, it drives cost across the system. Without upstream screening, timely intervention, and crisis stabilization, more people will cycle repeatedly through high-cost emergency services, law enforcement, and correctional systems. Every one of these outcome encounters comes with the financial cost to all taxpayers, a human cost to families, and an opportunity cost for capacity at our hospitals and our public safety agencies. We know the solution cannot be to build more crisis beds alone. We must embed behavioral health into the places people already receive care. National data shows that workplace mental health programs return about $5 for every $1 invested through reduced absenteeism and improved productivity. By integrating behavioral health with primary care, we can identify problems earlier, manage them more effectively, and reduce the need for costly interventions later. Behavioral health and primary care are two sides of the same coin. You cannot solve one without the other.
Thank you, Chris. Thank you, Philip, and thank you, Ryan, for your insight. You know, what Ryan just described about behavioral health is exactly why primary care matters so much. It is the one part of the system positioned to catch issues early. Whether a chronic physical condition, a behavioral health need, or perhaps both, primary care is well suited to manage them before they escalate into emergencies. And when primary care is accessible, and it's integrated, and it's well resourced, it doesn't just improve patient outcomes, it actually changes the economics of the whole system. Here in McLennan County, Waco Family Medicine is an incredibly effective tool for delivering that kind of care to our community. As our federally qualified health center, it provides comprehensive integrated services to tens of thousands of residents, many of whom have no other access point for care. When Waco Family Medicine has the resources to operate at full capacity, it manages chronic conditions very well. But they also address behavioral health needs there in those primary care clinics, and thus it keeps those patients out of our emergency room. And when it's under strain, as it is now, patients do spill over into higher cost settings. We've often said there's not a more expensive place to receive care than a hospital emergency room. And when all this happens, that's when our hospitals fill up with cases that could have been prevented and public costs climb. The PACES analysis, we put some hard numbers to this. For every $1 million invested in primary care in our community, the return is about 3.3 to 1. So when you add structured chronic disease management, or in other words, access to specialty care, which can often be efficiently delivered in those same primary care settings, hospitalizations drop another 25%, thus pushing that return on investment to 6.7 to 1. And by integrating behavioral health into primary care, it multiplies those benefits. It improves patient outcomes, reducing crises, and lowering overall system cost. What does this mean? Well, for employers in our community, it means fewer lost workdays and a healthier workforce. For taxpayers, it means a better return on every public dollar spent. For hospitals, it means capacity to grow and to innovate. But investment alone isn't enough. Right now, our city and county and hospitals and nonprofits all together fund pieces of the puzzle, often though without full coordination. We need a countywide planning and coordination function to align those investments, eliminate duplication, and ensure dollars are tied to measurable outcomes for our community. When you integrate primary care, behavioral health, and chronic disease management under a coordinated strategy, the potential is there to not just make the system more efficient, but it makes the system stronger, more stable, and thus better able to meet future demand. Primary care is our cost containment engine, and coordination is the driver. The PACES study reveals expanding primary care access and enhancing coordination efforts offer the potential and clearest path to bending the cost curve and building a system that works for every part of our great community. As we move through the presentation today, you've heard how current challenges show up in our hospital, in behavioral health, and in primary care, as well as the impact they have on Waco and McLennan County's workforce, our economy, and our local healthcare system's sustainability. I want to take a moment to pull those threads together and share what the data and lived experience of our providers tells us about the state of our healthcare system. First, our healthcare costs are rising faster than the revenues that support them. The three leaders to my right will immediately concur with that. It's the challenge they face every day they wake up and go into the office. That imbalance of putting the system on a path toward gradual erosion and eventual contraction if we do not intervene. Second, as we mentioned earlier and has been pointed out by the other leaders speaking this morning, 20.5% of our working age adults in Waco, which is nearly double the national average, are uninsured. This is not just a health statistic, it's a workforce risk. It's a productivity drag, and it's also a driver of higher public costs that our county commission and our city council wrestle with every year in balancing the budget. Third, fragmentation is costing us. Without any entity facilitating or coordinating the planning and funding, we see duplication of effort, misaligned investments, and missed opportunities to scale what works. And fourth, the highest returns come from upstream care like expanded access to primary care, adding structured chronic disease management, and integrating behavioral health. These are the interventions that reduce avoidable hospitalizations, lower cost, and thus improving outcomes. The work of the PACES task force makes one thing clear. We cannot solve these challenges with isolated efforts. We need a coordinated, sustained strategy that addresses both the medical and non-medical drivers of health. Based on our extensive research over the past couple of years in consultation and dialogue, the PACES task force offers 5 clear recommendations for us as a community going forward. First, we recommend prioritizing strategies that expand access to primary care, especially for the uninsured population. This is the single most cost-effective and impactful way to improve population health in McLennan County. Local analysis shows that investments in federally qualified health centers, such as our Waco Family Medicine, yield up to a 3-to-1 return, and reducing emergency room department utilization by as much as 25%. By strengthening Waco Family Medicine's capacity to deliver integrated primary care and behavioral health services is not only essential for patient care, it preserves hospital resources that are precious. It reduces costly inpatient stays and supports a healthier and a much more productive workforce for our economy. Second, we recommend initiating steps toward identifying a permanent organizational structure for PACES. This work will require dedicated leadership with deep expertise in healthcare systems, policy, and data. Whether through a new entity, an existing organization already in place in our community, or perhaps even a collaborative model, we must have a central structure. That's our goal. And this would be ideally with executive level staffing to lead it on a day-to-day basis, to oversee implementation, to oversee the coordination, and the sustained engagement of top community leaders. Third, we recommend that future financing discussions fully incorporate behavioral health needs. The burden of underfunded or unfunded behavioral health services drives up cost across the entire system. Any financial model that we consider must address these needs directly if we expect to stabilize the system and improve outcomes. And fourth, we recommend expanding outreach and engagement efforts to create a community-wide call to action. This means sharing our data in ways that are compelling to policymakers, to funders, to business leaders, and to the public. It means highlighting the cost of fragmented care and the opportunities for coordinated, sustainable improvement. It also means, and this is very important, listening through polling, listening through presentations, and public forums to ensure these strategies reflect the community's priorities. And finally, we recommend continuing the exploration of long-term structural and policy options that provide viable funding mechanisms. This work will require deliberate study, public education, and broad stakeholder input to build consensus before any changes can be proposed. As you can see, these recommendations are very well interconnected. Together, they form a strategic path forward, one that addresses immediate needs, builds the infrastructure for long-term success, and most importantly, positions Waco and McLennan County for a healthier, more economically resilient future. With that, that concludes our report, and I'll be happy to yield to the judge chairing this. I don't know if you want to break for lunch or open for questions at this time.
Well, I only came for lunch. Just kidding. I think we should. Let's break for lunch. And some of you just gonna have to hold your plates and eat. There are a few chairs that have lift ups on it. Let's get that, and then we can start a discussion if you choose to do so. With questions coming from folks, I guess, questions and
Yes, sir.
things like that.
Yes, sir.
Okay. All right. So, if y'all want to start?
as I said, I see two of our servant leaders finishing up, being served last there, so we'll go ahead and get started. I know we threw a lot of information at you this morning. It's something that we've been working with for over a couple of years, so it's somewhat familiar to us, but we thought it would be good, especially with those of you that are here today, to ask our county commissioners, our city council members, our mayor, our county judge, but especially so many of the staff members that are here, because what we're talking about is important to you, it's important to your departments, it's important to your jobs and your team and those kinds of things. And so we'd love to open the floor up for questions and answers, and hopefully we'll be able to do our very best. I've asked a co-facilitator, Ashley Allison, to join us at the table because she's been very instrumental in helping drive this process. So the floor is open for questions.
I'll start one.
Yes, sir.
A couple of questions. The report talked about the uninsured rate being higher in McLennan County than the state or the national level. How does that equate if providing more primary care? If you provide more primary care, how does that get that rate down? I mean, wouldn't it stay the same? Just more people have access, but they're still uninsured?
And I'll be happy to.
Does that make sense?
Yeah, it's a great question. It doesn't really, unfortunately, affect the uninsured rate. The challenge that we do have is that our uninsured citizens that are around us, and you know, sometimes there are some misnomers about the uninsured. Many people think they're unemployed, or there may be folks that hang out at our wonderful homeless shelters and those kinds of things, and they are a part of that. But a vast majority of the uninsured are hardworking McLennan County citizens that maybe they're self-employed, just can't afford it. Maybe they work for a smaller employer and it's not offered to them. It's been my experience, and again, I'm sure the experience of others on this panel, that they may have access to it. Their family budget just won't allow them to pay the premiums, and so they hope and pray they stay healthy and they forego it. But if we do increase our primary care, what we were thinking as a group is that it would increase access to care, so that these folks who are uninsured and cannot see a traditional family medicine physician in private practice very easily, they would have access to larger maybe cadre of physicians, perhaps through Waco Family Medicine, that would be able to open up and be able to see more patients. Chris, Philip, Ashley, y'all's thoughts on that?
Well, I think your point is valid, is that that's kind of a separate solution that has to be worked on, and how do we do it? I think Glenn is right that the challenge for us as health system executives is in reality things like primary care, the way reimbursement is done even on a national level. It's hard to make primary care clinics functional even with highly commercial insured. It's kind of a loss leader in the health just overall, and so that's one of the challenges. But I think you're right that what do we do about the uninsured rate just globally from McLennan County is kind of a separate solution that has to be thought about.
Good question.
I had one other.
Yes, sir.
I'll shut up.
No, this is good.
We periodically approve the, tell me if I'm right, acronyms, LPPF rates, reimbursements. And I know the report talks about a couple of scenarios with hospital districts being created in different ways. Would that go away, or would the LPPF continue if a hospital district was created, or a health district or hospital district? How does that affect the LPPF?
Because I've heard Glenn give this, I want to let him answer because he can answer it a lot better than I can.
Well, I mean, feel free to go ahead and take a stab at it if you'd like, then I'll be happy to.
No, go ahead.
All right. I think that, you know, as we look at across our community, we're faced with a number of challenges. There's no question about it. How much would a city or a county fund going forward? I think that would be later determined, because in order for us to pass, and we often use the term, and you referenced it, Commissioner Smith, is that we call it a hospital district. In our community, we don't have a county hospital. We don't have a JPS, John Peter Smith in Fort Worth, or Parkland, or University Hospital in San Antonio, or, on and on. Our two hospitals sitting at this table bear it on the chin each and every day. Chris and Philip may have a more up-to-date number. I know when I was sitting in Chris's chair, every Monday morning, we had to figure out how to earn $1.8 million that week to cover uncompensated care that would come in through our trauma center, through our emergency room every week. Can you imagine running a local business, knowing that every week you've got to go out and not receive, but earn on the bottom line $1.8 million? And that's what these two hospitals equally share in their burden through various means and various services. So we would propose that we look at, rather than examining a hospital district, maybe a health district. And a health district would be able to be more comprehensive and broader. But again, in order to fund that, we would need a lot of, as we outlined in the report, a lot of preliminary discussions with the community to see if our community has even an appetite for that. We would need to make sure that our voters would be willing to do that. It would start with going to the judge and getting him to sign a petition, then moving to the legislature and getting it passed through a local piece of legislation, and then taking it to the voters. And so those are, we see as big steps. As we sit before you this morning, we're not recommending that we necessarily go in that direction, but we do place it in front of you as one of many potential solutions. To answer your question specifically, then if you put that in place, it would all be, can the county and the city be relieved of a lot of the burden that you're carrying right now, and being able to replace that funding with any funding that perhaps would come from a potential hospital district, or excuse me, a health district. As we look across, we look at Corpus Christi, Nueces County, we look at Lubbock County, Weatherford up in Parker County, Amarillo and Randall County. We look at those, they have done that, and those are some good models that perhaps we could learn from, and seeing how they have done that. And so
I know we would certainly not want to do anything that would harm our two hospitals that perform admirably, and that would be certainly nothing that anyone would desire.
Right. I think, I think Chris and Philip were very kind this morning in not really telling you how tough it is in their shoes. I still get the privilege every day, each week, of working with peers of theirs across this nation. And it doesn't matter if you're in California or Colorado, Massachusetts, Texas, or Arkansas. Our hospital CEOs have a new day in front of them with the funding, the budget cuts that have just been passed. It's sizable, it's significant, and it's real. And so we appreciate your sensitivity of saying we need to keep our finger on the pulse, Commissioner Smith. I think you're exactly right.
Just, I know we're not there yet in the discernment process and where this is, but in those communities that you looked at that had healthcare districts, are those set up in a way where, if voter approved, their governing body is made up of elected officials, or are they appointed by the kind of constituent supporting entities, or how does that function in those communities?
Great question. That would really be up to you. That would be up to you as a community to decide, do you want those to be elected positions, which can create great opportunity for citizens, but it also can create a lot of other elements being brought to the table in different ways. It also creates cost of elections and those things which everyone is sensitive to. Many of the communities have gone to appointment, and those could be, again, how you craft it. It could be appointed by the county judge, by the county commission. It could be joint appointments by the city council and the county. We'd need to recognize other municipalities in our community in order to be fair, and make sure that everyone feels like they've got a voice in this whole process, because it wouldn't, if the decision was made to move forward, it would need to be a county-wide initiative for sure. But again, that would be your choosing of how you crafted it.
And I would just add, Josh, there's like specific legal counsel. We heard from some specific lawyers, and there is a section on page 22 that talks about the different kind of legal structures. So it's pretty complicated, and there's a lot of options there.
And this study just looks at the boundaries of McLennan County, not our MSA, right? Okay.
Jump in here. Proud once $3,000 contributor to your 1.8 million uncompensated care makeup need. When I was a working professional after Baylor at a small real estate firm that didn't offer insurance. But you mentioned, Chris, that primary care is a loss leader for you guys, generally speaking. Can you talk about a little bit kind of the incentive, the other benefits that come along with expanding access to that? Is it a shared load mentality? Is it a shared benefit mentality? When we look at expanding primary care to address the needs of our community, from an elected official standpoint, looking at the entire city of Waco, I see the benefit, but you have a business to run that, from your words just now, make it seem like increasing primary care visits, be it insured or uninsured, would kind of increase the gap you'd have to make up. Does that question make sense? And this can go to Philip as well.
Yeah, I think, and I'm sure there's other industries that are like this, but since I live in this one every day, it does seem unique that every year we know that expenses are going to go up and reimbursements going to go down, and so we see that. So every year, in a kind of a micro level, when you take it year by year and you're trying to figure out, hey, how do I make this year work? How do I prepare for the next 3 years? That's kind of always the question. Certainly there's, in our business, downstream kind of revenues that you try to do by keeping things in network, and that's kind of the strategies that health systems kind of use all over the country. I think one of the questions is, how do you maximize some of the benefits that are out there to offset some of those? We're very blessed to have Waco Family Medicine in this community, to have BHN, and so a lot of what we talk about is getting the right patient to the right place, and being able to utilize some of the enhanced reimbursement that does come at a federal level that's always in question, and you're always trying to figure out, hey, what's going to happen? And even in those programs, right, we see reimbursements going down, but there's always a question about what is out there and how do we maximize it. Again, Waco Family Medicine is a great program. It's a great, in our ecosystem, very important to what we do, and so it's very important for us to keep that and make sure that they are sustainable, because that benefits us tremendously.
Yeah.
So I don't know if that makes sense or answers some of that question.
I think, would it be fair to say that, this effort generally is to touch on the point you just made of to best determine what opportunities are out there and how to maximize them, that, sort of moving forward with this would allow you guys to explore that and maybe obtain sort of the maximization of those shared benefits?
Yeah.
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 Can you break down the 20% or 20.5%? You said that some of them are employed, or do you have that broke down to where you think some are employed and some are not employed, or the homeless or whatever? How does that break down?
I don't have that in front of me.
I don't know if we have a breakdown of like 20 that equals this, but we did contrast like the regular unemployment rate of Waco, which hovers around like 3.7% to the 20%. So I think those are the only two figures that we were able to. There is a lot of study that you can do to break that down if there was interest in following that. We had to really, the people who study this stuff are really proud of themselves and charge a lot of money. So we had to be kind of careful about what we were doing. But I think what we said is we want to focus on the people who are of the workforce age, working age.
Can I ask also, are there counties of similar size or setup, or maybe just a number of hospitals or care facilities that have a setup or structure like this that you can look at and model and steal from, essentially, to save on consultants' costs and all that jazz?
Yes. as we began this whole journey, we started looking at that very question, because I think that's right at the heart of the matter. In other words, why go out and reinvent the wheel? Sure. Probably a community that sometimes we like to be compared to, sometimes we don't like to be compared to, is just south of us on I-35 in Travis County. And they have done an amazing job there of putting in place a health district that is doing an excellent job of being able to reach out to the community, be able to provide greater access to care. And they were able to do that through that particular model. Many of the other communities across the state cobble it together in different ways. One of the things that was crystal clear to us, and it's already been reiterated by several of the team members already this morning, is that we have a blessing in this community that a lot of communities don't have, and that we not only have an FQHC, we've got a well-functioning FQHC, but we've also got an FQHC, a federally qualified health center, that not only provides outreach to the community, but also trains 12 new residents every year in family medicine. And so one of the things that we have seen in this community as we look at graduations, we look at those that finish that program, almost half stay here. And that is something that we have an edge on. And so to us, we see that as a great hope. We see that as a great promise for the community of being able to, how can we come alongside what we already have rather than trying to totally create something new and different? How do we come alongside and reinforce some of the blessings that we have in this community?
I think one thing that's apparent is we are one of the largest counties without some kind of healthcare district. Now, we may be smarter than everybody else, but I doubt it. And so looking into that is real important. But this discussion that we're having today started pre-COVID, which is now a well-used term. And things changed after that. But it was a broad-based group made up of health professionals, but also elected officials and all. Of course, all of us elected officials were going, wait, this is going to be more than likely a new taxing entity. And so the political animal and a lot of elected officials say, run away from that. There is some offset that could happen as well. And then you brought up about, how the governance is set up with them was important as well. But we knew back then, and finally we kind of cranked this discussion back up, is that there's going to take a lot of time, a lot of discussion, just like we're having today. And where you're learning something from this group, going forward, they're going to be learning from the folks out there that's going to be voting. And so we have to, we're going to have to get to a point that everybody kind of understands this thing and to decide exactly, what it's going to look like in the future. I think that especially the city and the counties, city councils across really need to, because they're an organized group, to really talk about this and how it affects their citizenry and those kind of things, and help encourage having these kind of conversations, get people there, and then there's going to take a lot of strategy. If you do decide to go to the legislature and go back to the local voters, which would have to happen under that possible structure of the district. So I'm glad to see this discussion come back up, because I know it's really important financially to many, but also what's the best thing for the citizens in our community too. So thinking about that health care, continuity care, access to care, all those kind of things, really dig down and be sure you understand that. And there's a lot of opportunity for people to really show you the inside of their operation a little bit more. The mental health piece, is, as you know, has become a bigger and bigger thing that we've invested more, and thanks to Representative Curry getting us some additional funding for that, but, we operate so separately that it just makes me think, and this would be coming from a lame duck, see, we're not afraid to say things, that there ought to be a more efficient way to do it. And if it is farming another taxing entity, you know, we need to say that's the route to go, but,
It's mentioned in the report that there are 141 hospital districts in the state right now. Are those all one county? Are some of them like, can that be multi-county?
I think they're countywide.
Those are just
I think that-
141 counties out of 254 have a hospital district.
Or have some sort of, some sort of entity that
Some
taxes.
sort of entity, okay.
I know there's been some crossing of county boundaries for other elements. You get down to the valley, I know there were 3 counties that came together that formed that first LPPF, that Local Provider Participation Fund. Commissioner Jones was very helpful in becoming interested in helping us as a county be able to implement this to help our hospitals. As far as hospital districts, we need to do some research on that, Commissioner Smith, to give you the final answer.
And then the other was just a thought, Judge, and a talking point. If you went forward and with asking the citizens to vote for this sort of a setup, it would relieve the counties and cities of that burden of providing it, which theoretically could depress your tax rate, because a large portion of ours goes to right now supporting different types of health care. So theoretically, it would relieve some of the burden on the counties and cities.
well, the good thing about going to the voters is it's going to the folks to make the decision. It's only on our backs to get it out there to them. It's on them
To
to
decide.
decide what they want to do.
Sure. Understood.
Can we equivocally say, can we absolutely say that the LPPF model, that the new model that we're looking at is more efficient than the LPPF model than what we're using right now?
Chris and Philip may have more insight into this. I know from my experience, what we're seeing is that the LPPF funding mechanisms are somewhat in jeopardy as we move.
I agree with that.
It's not as sustainable because anything could happen, as we know, and as we've seen in recent times, on a turn of a dime in Washington, it can happen pretty quickly, that we can lose access to those funds. There are some other funds, and we won't get off into the weeds too much, that both of our hospitals are very dependent on, that are also in the crosshairs. One of the other things we continue to worry about is our Waco Family Medicine, and we kind of circle back to that. They are totally dependent on a number of different resource mechanisms. As you know, the county that faithfully funds that, the city that faithfully funds that every year. Also, these 2 hospital systems sit here, Ascension and Baylor Scott and White, that they collectively support millions every year in direct cash into Waco Family Medicine to help support some of the services. How sustainable is that when these 2 health systems are facing enormous pressures? We worry about that. But then what we've seen in this past year are changes in Medicaid. And if you follow the funding mechanism of Waco Family Medicine, Medicaid is their greatest resource because they have the ability where Philip and Chris, their primary care doctors, see a Medicaid patient, they will get paid a much lesser amount of money. Under a federally qualified health center, which is mission is to reach out to those people that are medically underserved, i.e. the Medicaid population, as well as others. They are financially incentivized to see Medicaid patients. They will receive, there's a multiple to each patient visit is a different factor, but I would say 50 to 75% more each visit than these 2 health systems can collect because of their FQHC status. However, when you see a shift in our nation where Medicaid enrollment is about to go down and Medicaid funding to each state is very much in jeopardy, our state will no longer be able to cover as many Medicaid lives in our state. And the ripple effect of that would be further harm to Family Health Center. And so as we look at the federal piece, the state piece, Ascension, Baylor Scott and White, county, city, how can we make sure that we don't lose this precious resource that we have? Because I would say, if you ask us as a PACES committee if we could only vote for one thing that we're concerned about the most, I think we all would probably, or at least most of us, would land on the future of Family Health Center, being able to make sure that Jackson Griggs can continue to carry on the mission and ministry of that organization and the vital work they do in our community.
In the communities that have a healthcare district, as opposed to a hospital district, I guess, as a taxing entity, it's set up, does it then make disbursements per the board to the FQHC of the community or the LMHA of the community? Like, how does that function? Or are those supplemental income streams that just go automatically, or is it like a granting type?
It can go a variety of ways. And so we really didn't go into the structure of it. The only thing we did is we said, who's doing it? And there is, for the question of people that wanted to know, on page 26, there's a footnote. If you want to see the map of it, we did put the map of where the health districts are so you can see where they are. And then we kind of looked at what the options were, and there's a wide variety of options. Some of those districts can actually look at the uninsured rate and see if there's ways that they can use dollars to improve the uninsured rate. There's a lot of different kinds of things they can do, but this group wasn't about designing the district, because we're not going to be, none of us can be involved in that. We're just about what do people do to deal with this problem that we have.
Okay.
So it's more there.
And I think dovetailing onto what Ashley is saying, I think it'd really be up to the community to make that determination of where would you want those taxation dollars, that additional revenue, where would you want it to be steered? And I think if you look at the vital work our health department provides, we look at population health, we look at those kinds of things, that's a very important piece. We must continue that very important work in our community. I don't think that any of us would disagree that in 2020, if we never understood the vital, important work that goes on at the health department, I think all of us, really our eyes were fully open to the hard work that they have each and every day. And so there are a lot of different efforts that go on in this community under the health umbrella. And so it's the last thing we would want, I think, Chris and Philip can speak to this. I don't think you're hearing a voice from the two hospital systems of saying, we want this because we want a large amount of money. I'm certain they would not turn it away, but that is not the initiative here. The initiative here is how do we protect the whole of our community rather than any particular individual entity? How do we look at the safety net and the goodness of our community that goes on every day in the world of healthcare? Thoughts on that, gentlemen?
I just think it's important, the discussions we're having today are important, but it's not like taking one source off the table to then replace it with this. I think it's looking at where are still the gaps. And so it's not truly about LPPF, it's not about Medicaid. I think we all saw it this past year when Waco Family Medicine had to make some really hard changes. That was a 6% change in their Medicaid population just in a fail swoop. And so what this does, it allows communities to actually back up and be able to offer funding that they want to offer in the right place at the right time, so that when swings in Austin or swings in DC happen, the community is not set back. Our providers who are at the front lines, like Waco Family Medicine, are not having to make those decisions where they are scaling back those access points because they no longer have the federal funding.
Mm-hmm. Yeah, and just to beat Ryan's drum just a little bit, if you just look at the practicality of why this behavioral health piece has got to be integrated into all of this. You take a patient who has a mental illness, but they also are a diabetic. Till you get the mental illness stabilized, they're not going to be checking their blood sugars. They're not going to be regulating their insulin correctly, and that's when they hit the emergency room doors at Providence or Baylor Scott and White Hillcrest. And so you can see how all of this works together. And if we can embed behavioral health services more deeply into the primary care work, and some of you already know this in this room, Family Health Center is a national leader and how they have done that in many of their clinics. My concern is with the reduced funding, how much longer can they do that? And so we need to figure, because that's part of the secret sauce, and that's part of the solution, and we just need to come in and undergird that and support that even more.
Holmes over here, I'll chime in too. When we first started this group, about good healthcare, my perspective was, yeah, it'd be nice. Nice to have good healthcare in the community, but the longer I spend on this committee, I know it's an important driver of our economy. I'm an investment banker, so I try to put things in those kind of contexts, but having a strong workforce, having a healthy community, all points to having a good, strong community with smart growth. We've got visibly, we've got great infrastructure, it seems like, with Ascension and Baylor Scott and White. The leadership over there is amazing. Ryan, you're doing a great job with behavioral health. Jackson does such a great job over at Waco Family Medicine. So we got the visible components here within which we need to work. But rising costs, as you guys have mentioned, disproportionate emergency room care, which is not the best way to do things. The economics just aren't working. So we've got to pivot into something where there's a sure solution to the economics of taking care of all these parts. And really, a wake-up call, a flashpoint to me was, and nobody's fault here, but the DePaul Center closing down, so counterintuitive, right when mental health is so important that the economies wouldn't work on keeping that facility open. So we can't afford to have Central Texas healthcare deteriorate and erode. And so we're all trying to get together to figure out how do we backstop this thing and what structure do we use? So great group. Again, Chris, Philip, Ryan, Jackson, and Judge and Ashley, thanks for organizing all this, because we're kind of coming to a point here where this appears to be the plan that we're building around primary care, behavioral health, chronic disease management. I think all those that we've all mentioned, the best way to take care of those and how to coordinate it and make it more efficient for everybody. But all signs are kind of pointing to this health district construct. So I think we all owe it to ourselves to take a closer look about how that would work. And I think that's kind of the stage where we're at right now. And I think aren't we actually the most populous county that does not have a health district? I believe that's correct.
I think that's correct.
So I think Jimmy had that question.
Your cities seem to have them that Waco typically compares themselves to.
Right.
List.
So, yeah, I appreciate the work of this group, and it seems like we're to a nice juncture here to take it to the next step.
So what is the next step?
Well, that's really up to you as city council and county commissioners. I think our group, we feel like that we've tried to bring this forward over serving these past 2 years as a group of volunteers and folks extra time of bringing this and trying to put this report together. You've been gracious in your funding. You've been so supportive, many of you, and also attending many of the meetings that we've all been a part of. And so it's really, we present this report to you with some recommendations, and then it's really, you guide us, you guide the team. And I think that those of us that are volunteering on this, one of the recommendations was that if we really want to move this forward, do we perhaps create something of more permanence so that there is a true executive leader who's in place, who's got the experience, and be able to, with a small staff, be able to put that together. Is that a separate entity? Does it reside within the county? Does it reside within the city? Does it reside within a joint funded entity? That would be up to you,
Well,
our
the
elected
city
leaders.
of Waco and McLennan County have partnered on many things, and it's worked pretty well. And maybe understanding, and we ever so often have city-county meetings and discuss things like this, or posted meetings, and so I guess hearing from y'all maybe what the structure needs to be and to go forward. But I think there's, from those that have listened to the presentations, I think there's enough interest to take the next step towards saying what the next step is. And so if it needs to be a more formal structure, and I'm going to tell you, it needs to go on the road. It needs to be, because we have to get this out to the community to get feedback, to know if we're running against a brick wall or the door's open for more discussion, and I think that's what we'll see. But maybe the PACER group come up with a plan of the fast team, or whatever you want to call it, to go forward and, to get this out. But I'm not trying to speak for the city, but
Yeah, I
I
think,
like our partnership.
yeah, absolutely. I think Bradley and the team, and we'll all kind of figure out what next steps are for us and how we work with the court. But I think we're to a good place here right now. I know that Andrea had a question, right? Councilmember Mayor Pro Tem Bearfield.
It was, but it was about just exactly what Glenn spoke on, like where it would live. And so I guess moving forward, we're just going to have to sit down and circle the wagons and see what will work best for the organizational entity.
I would just point out that there's kind of two functions here when you think about that central coordination. One of them is just the data gathering function. So one of the most difficult things about being I'm a neutral facilitator, and that's my skill set. I do not have any kind of healthcare background. I have an economics background, and I run a community foundation. But there wasn't, this group doesn't get together. It doesn't gather central data and analyze it. So every decision about McLennan County healthcare is made by someone outside of Waco, if you think about it. Because there's not really a board or an entity with or without funding that gathers central data and evaluates what is best for our community and what do we need. So there's a data function that needs to be similar to how you have handled behavioral health with the BHLT. There's a similar function that needs to be done just for healthcare information and analytics and that data, because we had to create that function in order to do this report. And without this group, there's not really any funding source to gather that data and produce the data that can be used by any of you or the community for decision-making in the future, or to understand what the current state of healthcare is, or what are the costs, what are the things that are costing us the most, what are the things that are costing the Commissioners Court and the council the most from a healthcare spending perspective. So there's really not any entity. And then there's another entity that is a polling or a bringing to the community of options. And that may not need to be the same group, because you may need just to have this group the public people really look at the data, and then you might need to have a separate entity that's about, so I wouldn't saddle whatever the solution is. Public people don't need to be saddled with like a political decision.
Right.
So there's just two different functions there.
I would just add, so often, I think most of us in this room would agree as leaders, we've learned when we present something to someone, we must always understand that at the heart of it, no matter how loving all of us may be, at the end of the day, we're still selfish individuals. And so you hear a proposal like this, and it's like, okay, so what does this mean to me? What does this mean to me? And a mistake would be to come away of saying, well, this is really only about the 20.5% of the 1 in 5 in our community. That's what this is all about. Certainly, that's a piece of it. But I would submit to you that every one of us in this room are being affected already by what's happening in our community. And Mayor Holmes laid out a perfect example, DePaul. We would be an average group of people if in applying the statistic that somewhere in the lifetime of all of us in this room, 50% of us will experience some sort of mental health issue. On any given day, Chris runs a med-surg hospital. 1/3 of his patients have an underlying mental health condition. And so if 50% of us are going to have a mental health crisis in our life, and there's no DePaul in our community, where do we go? More importantly, or just as importantly, when our emergency rooms are overflowing with folks that could have been treated several weeks ago if they had access to a primary care, and now all of a sudden that infection is raging and they're being treated in Philip or Chris's emergency room, and then they're being transferred up to the ICU bay, you may say, well, that really doesn't affect me. Well, what happens when you come into the emergency room and all of their beds are filled? All the ICU beds are filled. And that affects all of us in the speed of care that these two leaders would like for all of us to be able to receive at their institutions. They can't deliver it fast enough today. Not every day is like that, but this past year, they would have the numbers of how many days you've had, how many you're completely holding patients in the emergency room. You walk into the hospital and there are patients in the hallway on gurneys waiting on ICU beds upstairs, waiting on step-down beds upstairs. That affects all of us. And if we look at nothing but economics and we look at nothing but growing our economic development function of this county, that's about attracting new businesses, new jobs. Smart business leaders, one of the questions they ask, tell me about your healthcare infrastructure. Well, today, we are blessed to have two nationally recognized health systems in our community, Ascension and Baylor Scott and White, well thought of with a high quality of care. But 5 years from now, if we don't address this problem today, what level of service, no matter how hard they try, no matter how much they fund, will they be able to provide our community? So I would say it affects all of us in this room today, what we've presented. Judge?
Yeah, over the last several years, well, for a good while, and City Manager Bradley Ford, myself, and Chris Collins at the Chamber are involved in recruiting companies coming into this community that we're now expecting, what are they going to do for us, not just what we're doing for them. And to understand that, you know, they're going to be part of the community, but the discussion always, after they find out whether there's enough water and there's enough gas, and are we training people here to work here and all these things, what kind of community are our employees going to live in? Are they going to live in a community that you have to drive a long way to get proper health care, or can we get it right here? And they're going to ask, you know, about schools and health care and the quality of life. You know, what do you have a vacuum, entertainment vacuum here, or do we have plenty of it? And so those are important questions, but it's always mentioned about health care and how we handle that. And, you know, our verbal pamphlet is that, you know, we are a regional medical community here, that we've got multiple ways of handling healthcare issues, from mental health to physical health and all those other things. So it is economic as well, that, you know, you have to get them here to be able to benefit from the taxes they pay. So I think it's something that we have been discussing, but we really need to get down and bear down about how we can be more efficient in what we're doing right now.
Anything else, team? All right. Thank you all so very much. We really appreciate your audience, appreciate everybody gathering today, and thank you for this time.
You bet. Thank y'all.
Thank you. Chad, you put the summary notes on number one on the agenda. The summary notes from last meeting.
All right, there's, y'all reviewed, if you haven't reviewed the summary notes and no additions or changes, is there a motion to approve? Thank you for coming.
So moved. Second.
Have a motion second, any other discussion? No other discussion, all in favor say aye. Aye. Opposed? Pass. What else? That it? We are adjourned.
Recording stopped.
Different camera, that's got my hair to it.